Okay, this is a short one just about sort of lived experience involvement and some of my experiences in that capacity before I became NHS staff and after. So I'll tell you about before. So I did some work with a university. I'd written my book, which I wouldn't publish for a further 10 years, and I emailed a nearby university and I said, I'd love to get involved in some of your teaching. Talk about my experiences with some of your students. And they got back to me. They were great. They said, come in for a meeting. I had a great meeting with the director of the program, or like one of the lead lecturers on the nursing degree. And he said, there's a company, a community interest company, that we do all of our lived experience work through. So if you join them, you can come to the next session, which is what I did. And that community interest company doesn't exist anymore, unfortunately, but it was a great space. Like, there were about 8 of us who got together once a fortnight, I think it was, to talk about how we were getting on, how we were managing our symptoms, how we were living in the community. And then we would get shipped off to this university and we would do a session where we all sat in a row in front of a classroom full of second year nursing students, I think it was. And we talked about our experiences. And I found that experience really positive. I felt really listened to, with one exception, but that was very strange. When I was sat in front of the students and I was telling my story, they were very supportive. They were really listening. They were nodding. They seemed to be taking value from what we were all saying, and it was a very positive experience. Then we were put into groups where we sat on a table with the students and they could ask us anything they wanted, and I sat on this table and no one asked me a question. So I said, well, this is awkward. And then one of the students made a real effort. He's a lovely man. He's now an RMN, and a good one. And he leaned forward and he said, Ollie, can I ask you about this aspect of your experience? And we had a great conversation. And then I turned to a young girl who was on my right, and she said something really interesting to me. She basically told me that one of her relatives had psychosis, and she said, when you see someone in that state, it's really hard to watch. And I had spent a lot of my time talking about the humour in my experiences, and I'd given quite a positive framing of psychosis. And I felt like she was sort of signalling to me either that she didn't believe I was really experiencing psychosis at the time of my admission, or that I had made a mockery of it. And I took that on board. I was like, that sounds really hard. But that was an interesting exchange because, for many reasons, about knowledge, power, so that was a real overall positive experience. When I then got a job working in psychiatry and joined the clinical education team doing the restraint training, I arrived late to a session for the induction for the new staff about a year later. And several of those students from the lived experience sessions at the university were in that training, and some of them recognized me and seemed quite happy to see me there. And that was a positive experience as well. I actually gave my book to the university before choosing to publish it many years later. And when I walked into the training session, one of the nurses said, "It's the guy who wrote the book." And I was really touched by that. I was like, "Oh, you read it? That's lovely." And the feedback from the university was that the students actually did like it. But it's a very long book, so I wouldn't have been offended if only a few of them read it. But it meant a lot to me. The second lived experience that I had was less positive, right? And the context of this lived experience involvement was very different. This was a training session run by the organization, and 2 former patients had been brought in as lived experience advisors, and they were greatly outnumbered. It was 2 of them and a room full of NHS mental health staff. And they were giving their suggestions about how to improve the patient experience on the ward. And what I noticed was that they were getting shut down repeatedly in quite a patronizing way. They would make a suggestion, and the response would be a sort of patronizing and dismissive explanation as to why this wouldn't work in clinical practice. Essentially, oh, that's a lovely idea, but we couldn't do that for reasons you don't understand because you don't do our job, right? And I could see the lived experience advisors getting quite frustrated. And so I chimed in and I said, well, I can weigh in on this as well, because I've been a patient on the ward that I now work, so I can offer a dual perspective. This fucked everybody up. It fucked the lived experience advisors up. It fucked the staff up. And one of the RMNs in the room said, but your staff. And I said, but I was a patient first. I did not understand the significance of what I had just done. Up until that point, I had effectively earned the not necessarily respect, but the tolerance of the staff group. I had been let in because I had, over a period of several months, demonstrated that I was functioning within the parameters of the organization's requirements. I was doing mental health the way mental health organizations want it done. And so I was seen by the staff as a defector. You've been a patient, you've had an experience, you've become well, and now you've come to our side. And you're on our side, right? By saying I was a patient first, I had reintroduced myself as a double agent. And the way that I was treated in that organization after that training session drastically changed. I was treated with a lot more suspicion. A lot of my work was more heavily supervised. I was more of a problem in the eyes of the organization. And this became worse and worse and worse, because I was somebody who pointed out problems in the organization and escalated issues and said, are we on the right side of the governance here? Is what we're doing on the ward consistent with what's in the policies and in law, you know? And I was told, you're causing a problem, right? And things happened, you know, as a result of that. And I was also told that senior management had said, I want him gone. I want him gone. So when it comes to lived experience involvement in mental health, it's a very mixed bag. Some people will be really interested in what you have to say. And in my experience, those outside of the organization, those who were preparing to go in, were very receptive. So I took away from that mental health staff in training are very open to lived experience. Obviously, this is anecdotal. This is just, you know, my experience. It doesn't generalize. But that was my first encounter with doing lived experience work. It was very positive. But when I saw lived experience involvement in the context of staff training in the NHS, it was much more tokenistic, much more. And there was a message that was being sent, which was, we, the mental health professionals, know things that you couldn't possibly understand about the system. And we can use that to basically say, yeah, no, nothing needs to change. And I had an encounter with one of the lived experience advisors who was struggling. He'd not long been discharged, and he was having lots of sort of breakthrough symptoms. He was struggling to get through that session, and I bumped into him in the men's toilet, and I just went for a piss and washed my hands, and he turned around and he said, "Come to rub it in." And I thought that was really interesting, and I said, "What do you mean?" And he said, "Oh, don't worry about it." And I said, "Oh, it's really nice to see you again." And I left. And when I think about that exchange, I think I had taken from him some of his role, right? I'd basically, they were brought there to be lived experience advisors. And by sharing my experience in that dual perspective, I had taken some of the emphasis off those guys. And I think he, for a number of reasons, partly because he was struggling with symptoms, and partly because it was probably very important to him that they listened to him, and partly because he'd been shut down so much, I think he was deeply frustrated. And yeah. So the last thing I'll say on all of this is that if you've ever worked on a psychiatric ward, you will know from experience that even the most deeply unwell patients, the ones that are the most completely disconnected from reality, still remain incredibly perceptive about the systemic issues in the organization. And if you want to understand how a mental health service is functioning, you should talk to inpatients, because they know what's going on, because they spend all day watching it play out and trying to get their needs met in the context of navigating those issues. If you ask staff, they won't give you the full picture because they're afraid there are consequences to being honest about what's going on. But the patients don't have that concern, right? To some extent, because in the sense that they're not embedded in the culture of the workplace. They have other concerns, their treatment, that, it's widely said that, like, what you say, your patient feedback won't affect your care. That's ethically and legally the case. But practically that's not the case, is it? So, but they have less concerns about being open about what's going on. So those are my thoughts, essentially, on lived experience involvement. It can be extremely positive, but it can also be tokenistic. And the things I've heard patients say about wards, many times they hit the nail exactly on the head, and they're wrestling with acute psychosis. And it's quite interesting, to witness. So there you go.